huge roles in a lot of different areas. And so I kind of joke that I'm sort of the center of all these different specialties as they overlap, and we see a lot of the same sorts of patients. A lot of my sickest patients obviously are going to be people who are dealing with suicidality, homicidality, these sorts of all sorts of psychiatric diseases that overlap with the ingestants that they may have intentionally or unintentionally exposed themselves to. And so we'll go through a case. This is going to be sort of the big case. It is a very rare case, so it is not something I would expect any of you guys to really know off the top of your head or be familiar with, but I'm just using this as a way to sort of how to go about thinking about a patient who may accidentally end up in a area that is intended for psychiatric disease, but actually has something else going on. So this case is one that I actually saw in fellowship down at Grady in Atlanta. We have a 19-year-old female who presents to the emergency department, brought in by mom for quote unquote abnormal behavior. Mom says that she's been less talkative, less interactive over the past couple of months, and it seems to have been progressive. What really brought her in today is mom was cooking dinner, called out to her daughter to say that dinner was ready, didn't get any answer, and so went up to go check on her and found that she's kind of staring off into space, not really paying attention. She yells at her a couple more times and then finally is snaps out of it, is like, oh yeah. And mom's like, you're being weird, I'm done with it, I'm taking you to the ER to go get checked out. She does have a history of bipolar, but is relatively well controlled. No obvious, evidence that she had any sort of overdose. She's denying any sort of suicidality, and only medical history is some anemia, but she takes iron supplements intermittently for that, but really hasn't had any major issues. The emergency department triage nurse asked one of the EM physicians to come and check her out and see if she needs to come back to the main department or go over to EPS. The emergency resident takes a quick look at her, basic exam, heart, lungs, that sort of thing. All overall looks relatively normal. They kind of hear the story and they're, well, I don't know, she's teenager, maybe she's just being sort of behaviorally difficult, maybe this is some depression, anhedonia, that sort of thing, and they decide, you know what, she's medically cleared, she can go over to EPS. So we'll come back to this case at the end once we have a little bit more information, but just keep this in mind. So both us and you guys as psychiatrists certainly have to deal with figuring out, well, is this truly a primary psychiatric disease versus something that is organic, in this case, toxicologic. The biggest number one way that you can do that is really vital sign abnormalities and physical exam. So vital signs, number one thing that's going to be abnormal in the case of an organic disease versus something that's primarily psychiatric. We also have this thing called toxidromes, and I know you guys are familiar with these from, both from experience and from your didactic. So toxidromes just being that constellation of signs and symptoms that are present, in particular intoxicants. So, an example being opioids going to have small pupils, decreased respirations, decreased level of consciousness, and that sort of thing. And then, so exposure history. Now, this is something that we'll talk about more specifically after we go through a couple different intoxicants. This is very important. So what sorts of medicines do they have access to? What are prescribed to them? What are in the household? What sorts of other, what we would refer to as xenobiotics or foreign substances might the patient have access to? Things like chemicals. Do they have fertilizer in the garage? Are they do they work at a smelting plant and are exposed to a bunch of metals? That sort of thing. All of those play into it, and we'll go into that more specifically. And then chronicity. If you wake up in the morning and you're normal, and by the afternoon you're having hallucinations, chances are that's probably going to be an organic disease versus a primary psychiatric disease. Certainly, weird things happen, but that courtesy can certainly help you sway you one way or the other. We're going to cover some common, but hopefully more obvious intoxicants. These are things that have very profound alterations in neurologic status and vital signs. And so hopefully these are not things that get missed by the medical teams that end up into the psychiatric unit, but can just something to be familiar with. And then another category we're going to get into is heavy metals. So what I've found is that when we're talking about diseases that might have very subtle physical exam findings, subtle physical symptomatology, and more profound psychiatric symptomatology, heavy metals tends to be a big category of these. And so we'll go through a couple specifics on that, but really like how to approach heavy metals as a broad category. And then we'll go back to our main case that is a very odd one, just sort of a zebra that is kind of fun to learn about. We're not going to cover drugs of abuse. We're not going to cover withdrawal symptoms. We're not going to cover Wernicke's or Korsakov's. You guys know that stuff. That's pretty general knowledge, and so I'm not going to get a lot into that. You could take an entire lecture on each one of those categories and go much more in depth. So I, as an emergency physician, would like to apologize for this term, excited delirium, that predominantly came out of our EMS systems that really got popular sort of like late 2010s, still in the lexicon of EMS providers and emergency medicine physicians. It is one of the most useless terms in medicine, and we still talk about it all the time. This is the constellation of these sorts of symptoms, so pain tolerance, tachypnea, sweating, agitation, generally in the setting of like pre-hospital. So this is an EMS provider going out, seeing somebody who's in the road, has different levels of, clothes are off and sweating and agitated. And, who knew that police non-compliance is apparently like pathologic. So if you don't comply with police commands, you automatically have some disease. But this is a very broad category of patients that incorporates toxicologic disease, psychiatric disease, organic disease, and it really gives us no information as to the etiology or even how to treat these patients. But luckily, the American College of Medical Toxicologists has, I can say this. It is a little bit. It is not quite out in the public yet, but the ACMT is actually trying to get rid of this term. And so they're building a position statement to formally denounce the term excited delirium. So hopefully that will be gone and by pretty soon here. Does anyone know what this plant might be? And it'll be our first intoxicant. I'll give you a hint because not everyone's a botanist. We've got this nice like 5-star flower. It's got some spiky leaves. First hint is it's got a little spiky seed pod. Might be a little more identifying. Takers.
Is it nightshade?
What's that?
Is it nightshade?
You're very close. It is in the same family.
Is that the belladonna flower?
Yeah, that's what I would have guessed. Or is that the same thing as nightshade?
It is the same family. So nightshade is a family of flowers. This is Datura stramonium. This is Jimson weed or devil's trumpet. Very, very similar. I'll give you 0.75 points for nightshade. This is so anticholinergic delirium. The plant itself can be used as a way of it can be abused, particularly in like teenage patients or college age patients. I saw a lot of this in Virginia, not so much here in Kentucky for whatever reason, but this plant is all over the East Coast. Every part of the plant contains what's called hycosamines, or things like scopolamine. You might remember from the patch. That's an antiemetic, and anti-motion sickness medication. But these are going to be, so anticholinergic, we all sort of know the mnemonic, the hot as a hare, blind as a bat, mad as a hatter, red as a beet. These are going to be patients that tend to be agitated. Sometimes they tend to be, every once in a while, more on the stuporous side, but generally going to be agitated, hallucinating. Now, their hallucinations are going to be particularly visual and tactile. And so what you will almost exclusively see with anticholinergic delirium is this kind of hallucination where the patient is picking things out of the air. It's almost as if like there are flies in the air that they're trying to get. And that's relatively specific for anticholinergic delirium. We do have an antidote for this. This is called physostigmine, which is a derivative of the calabar bean in Africa. That whole story is a lecture unto itself, but it's one of the best named brand name medicines that I know of. Antilirium tells you what it does. It opposes the delirium. And so it's a good antidote for anticholinergic delirium. It does not fix the other things, the cardiac toxicity, the tachycardia, the dry mucous membranes, all that other stuff. It doesn't really do a great job of fixing, but it will reverse their delirium pretty quickly. Honestly, physostigmine or antilirium has been unavailable for several years because of shortages. And so most of the time you're going to end up using benzodiazepines. But this should be fairly obvious to a medical provider. So the emergency department should be taking this patient and not sending them straight to EPS, for example. These are going to have very obvious physical signs and symptoms that clue you in that there's something else going on. And then we always talk about NMS versus serotonin syndrome. This is like, beat to death in almost every specialty. This is in your step one. Medicine residents talk about this. Emergency medicine talks about this. Psych residents talk about this. You got to know about it because you are going to be certainly interacting with these medications a lot. Serotonin syndrome is going to be, we call it serotonin toxicity now. Serotonin syndrome is sort of gone by the wayside, but it's going to be very abrupt. So literally going to be minutes to hours generally, following usually a combination of multiple serotonergic agents. It is going to be predominantly in the rigidity and hyperreflexia in the lower extremities. So ankle clonus is a very common physical exam finding that you might see in serotonin toxicity. And you're also going to see some GI effects because serotonin obviously has receptors in your GI tract. So nausea, diarrhea, that sort of thing. And then NMS is going to be more gradual. It might be days to weeks following exposure to an antipsychotic medication. It can also be abrupt withdrawal of a dopaminergic agent from, like a Parkinson's patient as an example of that. And these are really insidious, very slow, very prolonged, hard to diagnose, honestly. And the classic is going to be the lead pipe rigidity, particularly in the upper extremities. And their pupils are not going to be changed as you have mydriasis and the serotonin toxicity run. So again, these should be obvious to an emergency medicine provider or to a primary care provider, a medicine team. These should not end up primarily in the care of a psychiatric specialist. However, every once in a while, this is something that might pop up. Especially NMS can pop up, since it can be days to weeks after administration of an antipsychotic. You may see this sort of slowly grow in a patient that's admitted to a psychiatric unit for something else. And then the last of this, early obvious sort of toxicity category, we'll talk about carbon monoxide real briefly. So carbon monoxide is something that I love talking about because it's so controversial, both in, mechanisms and how to treat. But carbon monoxide is one of the leading toxicities in the United States. So between 95 and 2015, I believe is where this data comes from. It was the leading cause of unintentional death associated with poisonings in the United States. Since then, opioids have surpassed them, especially with the fentanyl analogs. So people are more unintentionally dying of those sorts of overdoses. But still a very big component of what a toxicologist might encounter. You're going to have some sort of source of incomplete combustion. So this is coming from like car exhaust, generators. Someone has a grill in the garage, whether it's poorly ventilated. Something like that is where you get carbon monoxide from. Initially, it presents with like headache, nausea, dizziness, those sort of very general, vague symptoms that may be confused with a flu-like illness. But then what really I want to point out about this disease entity is that the real issue with carbon monoxide toxicity is the CNS damage that it causes. Now, this may be immediate, but it can also be particularly delayed. It can be delayed up to 40 days after resolution of the initial exposure. And so what we find is that carbon monoxide patients often go on to have a very broad range of neuropsychiatric complaints that do not go away. These might be, anything from like an early dementia, amnestic syndrome, psychosis, Parkinsonism, paralysis, chorea, blindness, all this sort of stuff, all the way to, personality changes and learning difficulties, especially in children. There was actually a French study that looked at people who had significant carbon monoxide exposures and found that 50% of these patients at long-term follow-up, so a year to 2 years out, had a new diagnosis of a personality disorder. Now, obviously, there's going to be some bias in there. Not everyone is going in looking for personality disorders, and somebody who is not enrolled in the study, so there's a bit of observation bias associated with that study. But it does go to show you that there's this like real broad range of neurocognitive changes that occur as secondary to carbon monoxide. Can we prevent this or even treat it? Not really. So there's a couple studies looking at hyperbaric oxygen. We can blast, high pressures of oxygen into displacing the carbon monoxide from your blood cells and pushing out all the free radical oxidants that may be occurring even in the CNS and causing that damage. But statistically has not really bore out that we can do a whole lot both in preventing neurocognitive damage from carbon monoxide as well as delayed 40 days, month, 3 months out when you're actually finding these sort of neurocognitive symptoms. At that point, it's too late. In hyperbarics, it's not going to do anything in particular. You might get an MRI on these folks. They have some scattered, particularly basal ganglia, white matter changes, but very nonspecific, very difficult to treat. But it's one of those things to think about. And somebody who's got a new onset of some sort of behavioral disturbance, were they exposed to something like carbon monoxide in the past? Not everyone's going to make that connection themselves. And so it may be a question that you have to ask, like, hey, have you ever been in the hospital for carbon monoxide, or, you ever, attempt to take your life with a, car exhaust, or, all these sorts of things may clue you into a source of why someone might have a new onset of neurocognitive symptoms. Heavy metal testing. So this kid gets an A+ in heavy metal. But I just wanted to talk about like metal testing in general. This is one of the things that I find when you have a encephalopathy of unknown origin, and everyone gets consulted, psychiatry, neurology, in a place where toxicology is bigger, tox is involved, and a lot of people want to go, well, heavy metals on the differential, so let's test for all the heavy metals. Okay, well, what does that actually mean? There are a ton of heavy metals. If you've ever taken a look at a periodic table of elements, lots of metals, and almost all of those have some sort of disease state associated with too much of it. The problem is heavy metal toxicity is pretty rare. Reason being, we have an FDA and we have an EPA, and all those government agencies have done relatively good jobs at preventing disease states associated with these sorts of exposures. Big thing is that these are almost impossible to treat. And so really the big way that you're going to actually make a difference with regards to heavy metals is to reduce the chance of being exposed in the first place. Because of that, we don't see these very often. And it's a good thing, but at the same time, we don't have that much experience in treating heavy metal toxicities. So as a result of that, we don't have great tests for it either. There are a number of different heavy metals that we worry about, things like lead, arsenic, cadmium, manganese, mercury, those sorts of things. And each one has a specific gold standard test that's associated with it. For a lot of these, this is going to be a 24-hour urine. So 24-hour urine means somebody has to give you a jug, and that jug has to be metal-free, and that jug has to be filled with every urine that you produce over a 24-hour period and then turned into a lab in order to speciate each of the different heavy metals that come from it.
Dr. Eisenstat,
Yeah.
sorry to interrupt. I just had a quick question.
Yeah.
I mean, obviously there are, and this is just my ignorance, you know, there are like common ways that people are exposed to some heavy metals that we know about and learn about in med school. Does arsenic have a common environmental exposure, or is that something that we expect would have to be introduced?
Yeah, great question. Yeah, and most of these heavy metals have some, natural way that they might get into your system. Arsenic, for example, is in a lot of soil. So it gets taken up and bioaccumulated, particularly in fruits and vegetables. And so you might have seen back in 2011, Dr. Oz actually had this like big thing where he was like, oh, there's so much arsenic in your apple juice and everyone needs to stop drinking apple juice because of the arsenic. And it turns out there's different forms of arsenic, and the arsenic that they were testing for was not the toxic form. And it also, they did not use the correct form of testing. And so there is arsenic in your environment. You got to test for different speciations, is what we call it, of arsenic for the actual toxic ones. So it gets really, really complicated. And that's one of the reasons why you got to have a reason to be testing for these type of metals to really go down that pathway. It is really tempting to look at a list of labs and be like, oh, here's the spot urine heavy metal test, or here's the serum heavy metal test for X, Y, and Z. Those are generally not going to be particularly useful. Like I said, something like arsenic, you have to know, is it trivalent? Is it pentavalent arsenic? Is it organic or inorganic? And the only way you can figure that out is with this 24-hour urine test. A spot test is going to give you that total number. And that may be falsely elevated because of organic sources like in, fruits and veggies that are not actually going to cause disease. So that really plays into, sort of my bigger point, which is that you really gotta have some sort of reason to be going down the pathway of looking for heavy metals, even though a lot of these can cause neuropsychiatric changes and chronic exposures. These are generally going to be from things like occupational exposures. So my job is I'm a smelter, and I smelt different kinds of cadmium ores, and I'm exposed to cadmium vapor on a daily basis. And I'm not that great at putting my PPE on. I don't always wear my mask. I don't always wear my gloves, that sort of thing. That's really where you're going to get a lot of your metal exposures. We'll talk about lead, which is obviously like the most common one that a lot of people do end up getting exposed to. But you got to ask these sorts of questions. And we'll talk about what an exposure history is and how to do that. It's common that sometimes this comes from like a neurologist or some sort of primary care provider as an outpatient, where the basically get an entire panel of all these different metals, and they're not speciated and they're not done correctly. And those sorts of tests, I don't know what to do with. That's it's not going to give me any useful information. And if the history and the physical don't tell me that this is likely going to be a heavy metal exposure, very likely that person just wasted a lot of money and a lot of stress. So be very careful when you start to talk about heavy metals. Ask your experts. Your poison control is always going to be able to point you in the right direction on what to order if you are concerned about a heavy metal exposure. And we'll talk about a couple of these in sort of how they present in normal circumstances. So lead is probably the most common heavy metal that is symptomatic that we worry about. Lead has been in our environment, around us, in things that we consume and ingest for centuries and centuries and centuries. You probably all heard of the stories of Roman aquifers being lined with lead because it's so malleable and easily waterproofed. Long been known to cause behavioral changes, at very small chronic doses, all the way up to full-blown encephalopathy, coma, and death at very high levels. There's lots of different population studies on what lead encephalopathy actually does. But on average, you're looking at around 3 to 5 IQ point drop for every 10 points of a lead level. Now, IQ is not a perfect test. It is very biased, but over large populations, this has been shown to increase things like diagnosis of like neurodevelopmental disorders like ADHD, some more likely to have things like personality disorders over time. And so this does certainly on a population level cause a lot of problems, particularly in that it, especially in modern times, is going to be hitting people of lower socioeconomic status as a result of them being less likely to live in, let's say, houses that were remediated from lead paints, or be drinking water from sources that are remediated from lead piping. Flint, Michigan being the big example of that in the US. And what we know about this encephalopathy is that it does not resolve with chelation. So you can get other manifestations of lead, things like anemias, stomach cramps, stomach issues, that sort of thing. And that resolves really well with chelation, but the neurocognitive changes are going to be permanent. So lead is probably one of the things that we worry about the most on a population level. And prevention is always better than treatment, especially considering chelation is not that great. And so kids get screened. If you are of lower socioeconomic status, you are supposed to be screened at a higher frequency than other children. But a lot of these symptoms are going to be particularly difficult to pick up on if you're not screening for lead levels. Now, lead is one of the few heavy metals where a serum lead is the correct test. So you don't need to do like a 24-hour urine. You don't need to do any sort of crazy test, just a normal serum lead level. They can even do capillary lead levels for little kids. That's fine. That's going to be your gold standard test. Manganese. Now, manganese is a weirder one. This is certainly going to be less common, particularly going to be from occupational sources, so mining, smelting, battery production. You can get, the one case I saw in when we did outpatient toxicology clinic was from a well water source. There are also nutritional supplements that may have more manganese than is actually advertised. So remember that supplements are not really FDA regulated. They're under a act called DSHEA from the 1990s that basically like says, oh, you have to be safe, but that safety is not really like prospectively studied, it's retrospective. And so they can be fined or things can be taken off the market if there is a safety concern, but no one's really going in and testing all these supplements to make sure that they have the amount of each of these metals that they say they're going to have. This has been long known from, particularly from mining and smelting, but there is something called manganese madness, particularly going to be visual hallucinations, behavioral abnormalities, and this like reported decreased libido. Ultimately, at the end stage of this disease, it's going to be like a Parkinson's-like syndrome. But they're very interesting. There was an outbreak of manganese toxicity associated with this thing called methcathinone. So cathinone, you might actually be familiar with because that's the backbone of drugs like Wellbutrin, and it is also the backbone of the drugs of abuse known as the bath salts. But methcathinone was a decongestant from Russia that was abused that actually had a lot of manganese in it as an additive. And there was a case of 24 patients that had manganese toxicity as a result of this methcathinone abuse. And so we know a lot about the health effects of manganese as a result of this. Not a great chelator or anything to reduce the toxicity. You really just want to reduce exposure and keep patients from taking or being around whatever is causing their toxicity. Aluminum. This is a fun one. So aluminum has been known to cause toxicity since early 1900s. In Scandinavia, there were these big aluminum pots that were used in smelting facilities, and the aluminum would vaporize and cause this aluminum vapor and give people this what referred to as a pot room asthma or palsy. So it also caused neurologic symptoms. In modern times, we usually see this with dialysis. So if your water source has a lot of aluminum in it, it can actually get in the diacylate and cause a quote unquote dialysis dementia. It can be, balance problems, intention tremors, cognitive slowing, impaired memory, and bizarre behavior. All of this is very non-specific, so kind of tough to give you like a specific psychiatric diagnosis that's linked to. One of the interesting ways that people get exposed to this is through aluminum foil. So I don't know if you've ever seen this or had patients that have done this, but opioids, if you're not at the phase in your substance use disorder where you're using IV drugs, you may still smoke an opioid, and opioids, particularly black tar heroin, that's more common on the West Coast, and pills like Oxycontin can be smoked using a lighter underneath a thing of tinfoil. And this is called chasing the dragon. So as you light it and smoke the substance off the tinfoil, you move the tinfoil so as not to burn a hole in the foil, and it'll create this trail around the tinfoil, and it's referred to as chasing the dragon because you're chasing the smoke off this trail from the aluminum foil. This has actually been linked to aluminum encephalopathies in the past couple of years, and so there's a couple different sources for this. Again, not much to do about it. There's no good chelators or anything like that. You just want to stop the exposure. But something to think about, when you're talking to your patients about how they use their substances of abuse. And then mercury. Everyone, kind of knows about mercury from Alice in Wonderland, the Mad Hatter. This is commonly referred to as a Mad Hatter's disease, also referred to as the Danbury Shakes. So Danbury is a city in Connecticut where a lot of U.S. felt manufacturing occurred. Mercury in antiquity was used in fur manufacturing. It was also used as a medicine. So people would inject themselves with big syringes full of mercury in order to cure syphilis. And so sort of in kind of like funny irony, you have a lot of like people who, like very prominent like writers and actors and like intellectuals, people who would be more likely to contract syphilis actually contracted a mercury toxicity as a result of trying to treat their syphilis. And so there's lots of like interesting historical anecdotes of people being exposed to mercury in that way. You can always hear about like old dental amalgams containing mercury. There was a big concern about thimerosal, which is mercury in vaccinations. None of these have really been shown to cause any true toxicity, but always was, areas of somewhat of public concern, given the potential irreversible neurologic symptoms associated with mercury. People exposed to mercury are going to have fatigue, depression, interestingly, hypersensitivity to stimulus. So if they, like close the door around them, they're going to like, whoa, freak out. And then they had this intention tremor that's very common. They are also going to have other physical manifestations of this. There's something called erethism, which is redness of the palms and the soles of their feet, as well as kidney damage in particular. So this is not just going to be psychiatric, but the psychiatric symptoms are probably going to be the most prominent thing that brings people into the hospital. Hard to find mercury nowadays. There's not a lot of places that have it. Incandescent light bulbs actually have a little bit, upwards of 4 milligrams of elemental mercury in them. I remember I used to do construction when I was in high school, and we would take those long light bulb tubes, and we would sit in a dumpster and like fight each other with them and like hit them like lightsabers. And I just remember like all the dust and particulates coming off that and us breathing them in. So probably was exposed to some mercury from that. But it takes a lot of that to actually get into your system. So this is very rare. Now, the one place I have seen this, there was a, when I was in fellowship, there was a family physician in Georgia who probably had some underlying psychiatric disease that was undiagnosed. He was obsessed with the idea of alchemy. So he wanted to figure out a way to produce gold from other metals. And mercury is a very common, if you look at like alchemy of antiquity, mercury is a very common ingredient in a lot of these like experiments. And so he would go around from hotel room to hotel room trying his alchemy experiments, and it continuously exposed himself to mercury fumes. And we actually did have to chelate that guy for mercury toxicity, but he was like already probably had some underlying psychiatric disease, but it certainly escalated as a result of his mercury toxicity. So how to take an exposure history. This is probably like the biggest takeaway that you guys can get from this. We can go into each of these metals for like hours and talk about them. You want to know anything that people should not have in their body that they might be exposed to. So this is, medication. So prescribed medications, over-the-counter medications. Got to think about supplements. So most people do not consider their daily vitamin or their ginkgo biloba or their omega-3 fatty acids that they take to be medicines. So you specifically got to ask them, do you take any over-the-counter supplements, anything from GNC or the health food store? All of those can potentially be a part of their exposure. Special dietary restrictions. So some people may not think of their, whatever cleanse they're on to be, impactful in their health, but they may actually be exposed to very large amounts of some over-the-counter supplement. So occupations and big one. So what are they exposed to at work? Are they in mining? Are they in smelting? Are they do they do glass etching? Do they do painting? What are they exposed to on a daily basis? These are going to be their big exposures. Remember, you're at work for 8 hours a day, 5-6 days out of the week. And so this is going to be a large part of what you're exposed to in a normal day. You got to ask about PPE. Do they wear respirators? Do they wear gloves? Are they touching anything with their bare hand that they shouldn't be? Is there times at which they take their PPE off and perhaps smell a chemical or have a chemical on their skin? You also want to ask where they live. So is it a house or is it an apartment? Is it in the city or is it out in the middle of nowhere? Is it city water or is it well water? Manganese is much more common in well water. So you want to know what potential metals might be exposed in the water source. You want to know, are they near any factories? Are you, 30 feet away from the nuclear reactor and now you're growing a third arm out of the middle of your chest? Those are the things you want to know what you potentially could be exposed to. Hobbies as well. See a lot of painters, see a lot of people who do, so etching exposes you to a lot of acids that can be particularly toxic. Do you go to the firing range and have a firing range on your property where you might have more lead casings that get seeps into your well water? Those sorts of things can all play into whether or not you think somebody might have a heavy metal toxic exposure. And then concerns for poisonings, you know, obviously, like most people who come in and say their husband is poisoning them, it's not real. But every once in a while, it's true. Obviously, you know, like last night, if you watched the Oscars, Navalny was the Oscar winner for Best Documentary. That was a story about Alexei Navalny was a Russian dissident who was poisoned by Putin with an organophosphate called Novichok in a glass of tea that he had before his airplane ride. So if you're like a political dissident, you know, maybe you got some concerns about assassination attempts. All of this, when you start to take these exposure histories, you start to look like Charlie Day and Always Sunny in Philadelphia. You sound kind of crazy, but it's always better to have more information than less. So let's go back to the case. We'll finish up with this. During your assessment of this patient, remember this is your 19-year-old that came in for kind of some slowing cognitively, some decreased interactiveness. During your assessment, you notice that the patient is having some trouble sitting up. So they're having truncal ataxia. Quick neuro exam shows their finger to nose is a little off. They're a little slow to get to it. And so another source of ataxia. Do a mini mental status exam, you know, not the best screening, but it's a pretty good quick screen for cognitive functions. And she's got a 23 out of 30. It's, you know, not crazy low, but it's a little low. You know, it's certainly in the abnormal range. And for a 19-year-old who's otherwise healthy and doesn't have any like visual impairments or anything like that, that's a very abnormal score. And then mom mentions, oh, by the way, she has a history of anemia and some pica. So she's been eating random things around the house, a little bit of paper, some dirt every once in a while. She's caught her eating. She's constantly chewing on ice, that sort of thing. And you get her in a robe and you notice that this is the rash that you see. So very dark pigmentation. It's going to be very dry, very scaly, particularly over the arms and the upper legs. And this is paradichlorobenzene, which I'm sure you all knew about. This is actually a deodorizer that is commonly found in urinal cakes. And so people with a history of pica and anemia, there have been instances of people eating these urinal cakes for whatever reason. It's a bit, you know, it's like part compulsion, part as a result of the anemia itself, but it leads to toxicity from paradichlorobenzene, which is also in mothballs. So if you look at a mothball or a urinal cake, any of these in modern times are going to be paradichlorobenzene. It causes generally mostly neurocognitive effects. There's going to be memory impairment. There's going to be slowing of higher level functioning. Generally, you can get some depressions, not generally usually overt psychosis, but certainly something that a family member is going to pick up on. You also get ataxias, so truncal and peripheral ataxias, as well as some cardiac effects. So it does cause cardiac toxicity, and that's actually how they generally die if they are going to die from this exposure. Known for being very lipophilic. So what happens, unfortunately, a lot is people will ingest a lot of this, get it stored up in their fat cells, and then as a result of their cognitive decline, they kind of stop eating. And then as they starve, their fat stores break down, and that paradichlorobenzene goes back into their system and causes more toxicity. So they get sicker and sicker unless you actually like get them on, highly nutritional regimens and keep a close eye on them to make sure that their compulsion to eat these paradichlorobenzene substances is alleviated. All right, so that's all I got. Take home points: be vigilant. My emergency physician colleagues are good. They're not perfect. They're not great. Things slip through the cracks, and so every once in a while you might get a tox patient that they think is a psych patient. Good history and physical always trumps any sort of test. Learn to practice your exposure history. Ask about things like hobbies, ask about their water source, ask about their home. All these sorts of things might clue you in that there's something off. Don't haphazardly test for heavy metals. Have a specific reason that you're testing for heavy metals, and then get an expert to help you figure out how to test. And usually that's going to be the Poison Center, available 24/7. It's always free. We're always welcome to hear from you guys or anyone else who needs a tox consult over the phone. But that's all I got. Do you guys have any questions for me? I know that's a lot in an hour. Only get, kind of cover the surface level stuff, but hopefully that was interesting to you guys.
So this patient was eating urinal cakes.
Yeah, she was eating urinal cakes.
Where did she obtain them?
So we never figured that out. She was not particularly cooperative. Unfortunately, she was lost to follow-up. So we ended up getting a single MRI on her that was normal, but she did have many mental status changes, particularly like recall and memory issues. We had a second patient about a year earlier that unfortunately died of electrolyte abnormalities associated with paradichlorobenzene. This is fairly rare. It was weird that we had 2 patients at Grady within a couple of years. There's only about 15 of these cases, and reported to poison centers over about 20 years. And so these are very strange. But it's kind of one of those things, like if you actually talk to mom, she was like, oh yeah, there was I found a urinal cake under her pillow. I found this pink residue all over the place. And mom was really the reason that we sort of got clued into this.
Huh. Yeah, those are very interesting presentation. Thank you.
Yeah, of course.
This might be a silly question. Yeah, firstly, thank you so much. This is not something we get any formal education on. And of course, as psychiatrists, sometimes we are being handed these patients without a ton of context. And it's also really difficult because sometimes they can't really tell you any useful information, and even harder is when you can't find family to give you any good information. You're very familiar with working from nothing with a patient. I have a lot of questions about this presentation, but I didn't want to ask specifically because anticholinergic toxicity is something that we are most likely to see out of all of these. Now, how often do you get the entire constellation of symptoms with the hyperthermia and the mydriasis and the urinary retention? And if it's not very often, then what are the most common or initial presenting symptoms of anticholinergic toxicity?
Yeah, very good point. There is definitely a spectrum of disease. So initial things that you're going to see are going to be tachycardia, anxiety, and mydriasis. So those are going to generally be your mild symptoms that you see in almost every patient. GI slowing, urinary retention, and hyperthermia are going to be much more severe. And hyperthermia is the worst. So I always tell my residents when I'm talking to them about anticholinergic toxicity, the one thing I want to know is the patient's core temperature. So hyperthermia is sort of the end. And then you start to see cardiac toxicity, seizure, death, and it goes into a spiral. The very subtle findings generally going to be dry mouth, wide pupils, tachycardia, maybe a little bit of anxiety, and then as it progresses, then you get visual hallucinations. So that's sort of the progression. Now, not every patient reads the textbook, right? So I've seen a couple of cases where you get urinary retention, but not really the mydriasis. I had one patient. We had one case that was really bizarre, where we thought she had a neurologic, traumatic brain injury. Came in from a car accident, had one blown pupil. Turns out she had taken a bunch of Benadryl before crashing her car. And that blown pupil only on one side was because she had a glass eye in the other. It was actually a really good glass eye. And so it took us a while to figure out that it was not a real eye. And so things are, sometimes there are abnormalities in that presentation. But definitely hyperthermia is on the severe side. Agitation, tachycardia, mydriasis on the less severe side.
Thank you for clarifying that.
Of
Super
course.
helpful.
And guys, I got to run to another meeting. I'm sorry. I wish I could take more questions, but I'm going to run away. Thank you so much for having me. If you can always reach out to the emergency department if you ever want to, hear from any of us for a lecture or cross collaborate with us for any reason. Otherwise, I'll see you around. Where I'm in the department a lot, so if you ever have any tox questions and I'm in the department, I'm always happy to help.
Thank you so much. This was absolutely fantastic. We really appreciate your time. Thank you.
Thank you, guys.